So in this last video, we're going to talk about some applications of economic epidemiology in practice. In 1980s in San Francisco, the HIV epidemic was spreading. So the infection hazard rate is the rate at which people who are susceptible to a disease end up becoming infected. And in the 1980s in San Francisco, as the prevalence was growing, the number of new cases each year, the incidence rate, was declining because people began taking precautions, which suggests a positive prevalence elasticity, meaning that the demand for self-protection goes up when the prevalence goes up. In 1989, there was a big measles epidemic in the United States, but not all states were hit the same. So some places like Texas had a lot of cases. Others like North Dakota had very few. So if you think about it, if we were to compare how many people in Texas versus North Dakota were getting their kids vaccinated, if there was a zero prevalence elasticity, what would we expect between the two versus if it's a positive prevalence elasticity? So if there's a zero prevalence elasticity, that means that regardless of how many people have the disease, it really doesn't change how much people decide to get vaccinated or to protect themselves. Versus if it's a positive prevalence elasticity, that means that as more and more people have this disease, as you're hearing about more people who have it, you're going to be more likely to get vaccinated or do whatever you can to prevent having it. So what you end up finding is the latter. There was a positive prevalence elasticity. So parents in the higher prevalence states like Texas started bringing their kids in for vaccines much earlier and more consistently than the parents in the low prevalence states. At first, though, like in the earlier years, the vaccine rates were pretty similar. So it's not like people in Texas just love vaccines necessarily. It's more so that they were responding to the growing prevalence in their state, which suggests that the demand for that measles vaccine was prevalence elastic. Something similar with condom use across different states depending on their prevalence of AIDS. So condom use was fairly similar at first, similarly to measles vaccination rates. Condom use was fairly similar at first, like as of 1984, between high and low prevalence states. But by 1990, there was a lot more awareness of the connection between HIV and having unprotected sex. And so that at that point, people started responding to the different rates of prevalence. So at-risk single men in those high prevalence AIDS states were a lot more likely to start using condoms, and they were using them more consistently than their counterparts in a low prevalence state, even by 1990. So in the last 5 years of the 1980s, information began to spread, and people's demand for protection started to respond to those rates. You find something similar with flu vaccinations. So using survey data from the late 90s, you find that more people decided to get that flu vaccine in states where the year before that there was a lot of flu. And also more people are getting flu vaccines if there was a lot of flu deaths in their state the year before. So that suggests a prevalence elasticity, that people are responding to how many people have the disease, but also a mortality elasticity where people's demand for self-protection is associated with deaths from the disease. So in conclusion from this chapter, essentially, we do have evidence that people's demand for self-protection is based on the prevalence and severity of a disease. And, the implications this have for policy, essentially, we can invest in treatment and or in prevention, and deciding on the mix between the two depends on prevalence elasticity for the population. So if we invest all of our money in treatment and the prevalence goes down, then we know that if people's demand for self-protection is highly associated with that, they're no longer going to invest in their own treatment, in their own prevention as the prevalence goes down. So we have to keep that in mind and invest also in prevention. And in order to get all the way down to fully eradication of the disease, it's likely that we're going to have to invest even more so in prevention because we know about this prevalence elasticity phenomenon, even getting to the point where perhaps the cost of obtaining the vaccination is negative. Sometimes you just have to pay people to get vaccinated when it's a disease that has a low prevalence and they think like, oh, I'm never going to get it. So that's it for chapter 21. That's it for this week.